Yeah.
Well, good afternoon, everyone, and welcome to Public Health's virtual education series, Wazooki wo Ehi, Family Conversations. I am Renelle, public health nurse, and we are not joined today with Jamie Decora, but I will try to moderate this session on my own. The goal of this series is to gather, learn, and share about Ho-Chunk culture, resources, services, and the connection to health. In public health, we focus on prevention, promotion, and the protection of health and the well-being of our communities. Health and well-being are rooted in many aspects of our lives, from our physical body, our mental health, our spirit, the environment we live in, and much more. During these sessions, we will explore topics that can impact our health and well-being. Together, we will learn about tools and resources to improve our health and the health of our communities. Today, we're joined by Chelsea Van Gundy from the Toma VA. She will be sharing information on how we can support our veterans, their families, and caregivers to prevent suicide. We will have about 45 minutes for the presentation, followed by Q&A. You can use the chat function to enter any comments or questions for our presenter, and I will monitor the chat throughout the presentation. You can also come off mute at any time during the presentation to offer comments or ask questions. If there are any questions that we don't have time for, we will forward to Chelsea to respond by email. This session is being recorded and will be posted on the Department of Health website and our Facebook page. Everyone, please welcome Chelsea.
Hi, thank you, Renelle, for having me. I really appreciate being here and being able to present. I'm with the suicide prevention team at the Toma VA. I am kind of our public facing, it's called Community Engagement Partnership Coordinator. I've only been in this role about 2 months, and you might be familiar with my predecessor, Carol Ewald, who did a phenomenal job in the role. I work very closely with our in-house suicide prevention team clinically, but I also am community facing as well and kind of available as a resource for all of our partners. So today I'm going to give some information on suicide prevention. It's going to be a little bit public health. It's going to be a little bit like VA SAVE training and a little bit from my clinical background. So I'm a clinical social worker. I did that for 11 years prior to coming in this role, and primarily working in our urgent care doing our mental health triage. So I have a lot of experience, a lot of years of experience doing this. I saw between, on average, like 75 and 120 people per year specifically for suicidal ideation. So kind of live, breathe, ate all of this for many years. And I'm very excited to be able to kind of share what we know and what we've learned with the community. So just before we begin, this is a very heavy, emotionally heavy topic. For myself, you never get desensitized to it. It's tough to talk about. So I want to keep it open if you guys have questions or comments. If you feel kind of compelled to say something or ask a question, feel free to interrupt or throw it in the chat. If you kind of are holding all this in and just kind of sitting with it, that's okay too. So whatever you guys need, or if you need to take a break too. I just want to make sure you're aware of immediate resources. So we have 988 that's available. If you're a veteran, press 1. Not just for crises, even though it's called the crisis line, but they're like immediate counselors on the other end too. It's a phenomenal resource. So suicide is preventable. You don't have to be an expert. You don't have to be a clinician to talk about suicide or offer to support someone. So I'll give some examples kind of later on of how I've responded to situations as a clinician, but then also kind of personally as a layperson too. And then the way someone feels supported is going to really vary based on each person. Main thing, listen without judgment. Just be a kind of present observer of everything that's going on, and you really can't go wrong. And then when suicide is brought up in a conversation, even casually, please take it seriously. Don't need to freak out and be calling police right away, but even just those kind of like mild statements kind of prove to be sometimes concerning or need intervention. So All right. So I'm just going to start off with kind of a larger overview of this as a public health issue. A lot of societal factors. Seen a huge spike since COVID, and then all of the like restrictions and isolation since then. Um, a lot of things go into suicide risk, economic disparities. There's big veins along race and ethnicity with suicide risk, LGBT community, homelessness, isolation, all those kind of play a part, and I'll tease those out a little bit more as we go forward. Um, for every suicide, it affects an estimated 135 surviving individuals. That's a lot. We're thinking about like postvention care for every one death, trying to reach all those people and provide support. Really huge impact, and that's just kind of directly affecting. That's not even like the secondary. Even if you didn't really close with a person, you're still affected by it. So, and then the VA's national strategy for preventing veteran suicide, really a mixture of evidence-based clinical interventions. We have a whole team of PhD people high up that study this day in and day out and kind of pass along what's working, what's not working, both in terms of clinical interventions and like community-based interventions as well. So really good resource there. So looking at clinical interventions, but also looking at community prevention strategies. Oh, and my sentence cut off there. Sorry. So I just wanted to briefly go over the 2025 National Veteran Suicide Prevention Report. Hot off the press, it just got released. I was telling Renell, it's like we haven't really had a good chance to dissect it. So this is just kind of at a glance stuff that I pulled. So 61% of veterans who died by suicide in 2023, and the most up-to-date statistics are going to be from 2023 because this is a report that was due last year. So, and they look back 2 years. So 61% that died by suicide in 2023 were not receiving VA health care. We know that getting people enrolled and engaged in VA care is an enormous protective factor. Our folks that are particularly at risk are ones that are not receiving any VA care and those that use community care. So it's kind of something to keep in mind as we look at the strategy and trying to reach veterans. Suicide rate for female veterans is 103% higher than for female non-veterans. And the adjusted rate for male veterans is 49% higher than non-male veterans. Young veterans age 18 to 34 have rates 2 times higher than non-veteran peers. And then the second group was 35 to 54. And that's 18 to 34 is really a group we've honed in on recently with trying to have a memorandum of understanding with the DoD, really provide hands-on like transition help. We have our military to VA program that provides case management, but really trying to pay attention to that young group because it's the highest, that 6 months post-discharge is the highest lifetime risk for suicide. And you can even break it down by branch, like Marine Corps and Army, 6 months post-discharge, way higher than like Air Force and Navy. So they get really in the weeds with a lot of this stuff. Veterans in healthcare with in VA care with diagnosis of traumatic brain injury had 94% higher risk than veterans without traumatic brain injury. And then the suicide rate among homeless veterans was 146% higher. Some additional risk factors that they found from that 2023 data was a cancer diagnosis. I think that was like 10% higher. The branch of service I kind of mentioned. Pain is a huge one that's not new as a veteran issue. Race, they found white and Native veterans had the highest risk. Black and Asian veterans had the lowest risk, and financial status. So those that were lower income had a higher risk as well. So I did include a link. There's links all throughout this, and I can email this out too if you guys are interested. Suicide is a really complex issue. Part of my role is doing like forensic chart reviews. So anytime we have a death, I'm part of the team that looks through and tries to peel through what happened, what was missed, where could we done more support. And I will say everyone is so incredibly different. So we try to pull together some common themes We were able to identify some underlying risk factors. We're able to pull together what are some protective factors so we have a good picture of what to look for when somebody's sitting in front of us of kind of like where things are at. So risk factors in general, those are characteristics that are associated with increased likelihood of suicide behaviors. Generally speaking, same for protective factors. Those are factors that can help offset risk factors. So on an individual level, strategy is trying to maximize protective factors, minimizing risk factors with both individuals and communities. Kind of looking at some of the like societal, like macro level stuff, why an increase? Suicide rates are back up on the rise, not just for veterans. Had a big spike after COVID-19. Financial strain, cost of living is really tough right now. Housing instability, socio-political instability, anxiety, depression, alcohol misuse and abuse, family relationship stressors, and the big one I'm going to focus a lot on is firearm access. Things that we know really decrease suicide risk at a higher level, healthcare access and use, social support, community integration, that isolation, the social isolation piece is a huge one, and secure access to firearms is another big protective factor. So individual risk and protective factors, you can kind of read through. A lot of them are, I don't want to say common sense, but just kind of make sense at surface level. These are on an individual level, things that we look for that might help us identify veterans that are higher risk. So things like mental health issues, prior attempts, kind of acute psychosocial stressors, relationship issues is the biggest one. That seems to be a very common theme last few years. Big protective factors, access to care, connectedness, spirituality, having a mission or purpose. That's a question that the VA now asks all of our veterans all the time is, what's your mission? What's your aspiration? What's your purpose in life? Physical health, employment, and then kind of touching again on secure storage, firearm secure storage. Some historical risk factors that might put somebody at higher risk: having a previous suicide attempt, having a family or friend lost through suicide. There's a huge emphasis these days on post-vention care. I'm helping Monroe County get a post-vention program off the ground because they tend to see it like boom, 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 that really affects the community at large. Victim of childhood abuse, witnessing family violence, previously abused drug or alcohol, and then alcohol abuse or dependence by a significant family member too. Triggers, this is some Army data I pulled, but 75% of suicides in the Army were triggered by relationship problems. I can say with certainty that's probably consistent with our veteran population. We're seeing a lot of like kind of divorce or significant other moved on, breakups, bad breakups. That seems to be a really common theme. So that tells us that we need to pay attention to people more when they're going through that relationship problem that we know about. 50% occurred while pending UCMJ, so like justice involved. 42% experiencing financial problems, 34% having drug and alcohol problems. So those are kind of like acute triggers. The historical factors are kind of underlying things that predispose someone to the risk, and then these are kind of speaking to some of the acute triggers we see. So the VA suicide prevention strategy, we kind of looking at all these things: promoting firearm storage, having readily available crisis intervention storage. The rollout of 988 was huge a few years ago. Implementing and sustaining community collaborations. Only 50% of veterans get their care in the VA, so we're doing all this work in-house and take care of our folks, but we're not touching 50% of the veteran population. We're trying to do that more through community collaborations, improved tailoring of prevention intervention services, advancing suicide prevention meaningfully into non-clinical support intervention services, increasing access to and utilization of mental health care, and then integrating suicide prevention within medical settings. So not everybody wants to go to therapy, not everybody wants to take medications. So can we still help those folks in other settings that they access? Just briefly, I want to go over suicide risk curve. So this is very clinical. This is what we're kind of looking at when somebody's in front of us. And I think it's really helpful for the community at large to kind of be aware of, like, how does a suicidal crisis work? So we kind of start down here, and this is where somebody already has those historical risk factors at play. So they come into a situation, maybe they struggle with PTSD, maybe they are a victim of childhood abuse, kind of things that might already elevate their risk. And then there's some sort of trigger that goes on. This is unique for everybody. Maybe they felt slighted or embarrassed, like got humiliated at work, or again, like a relationship stressor, PTSD exacerbation, like something kind of comes along and starts them on that path towards crisis. So when we look at the suicide risk curve, we want to intervene early, like at the time of the trigger or before the trigger. That's when we're going to be most effective. So some of the things that we work with people on is recognizing those triggers, like what's really distressing to you, what's going to push you to that dark place, and having that self-awareness and a strategy for yourself to either remove yourself from a situation. How are you going to cope when that happens? And then, so as we move along, then we go to our crisis point. This is where people act on those thoughts. And we've found that this stage, the highest point, only lasts about 10 to 40 minutes. Very short, very brief. And so we want to equip people, like when you're in that crisis, like what are you going to do? Have something easily accessible. And that's why 988 has been so instrumental in this, is that you have a number you can just quickly dial. And lethal means safety planning is so integral, because we know, especially our veterans, really high rates of suicide by firearm, about 75%. And it's so quick and it's so lethal. And so you put time and space in between identified means, it helps keep people alive. And then we're coming back down and kind of the after, the consequences of that. We see a lot of people at this point as well. So maybe they had their suicidal crisis yesterday, they got through it, they decided, like, I need to get some help. And so we're seeing them kind of after the fact and able to kind of reflect on what happened and tie that into a good safety plan for them. So just wanted to quickly kind of go over that. Access to lethal means is a huge risk factor. It's so quick, it's so lethal compared to other methods. Looking at the data again, 73.5% of veteran suicides are by firearm. Veterans are highly likely to have at least one firearm in their house, and they're very highly likely to have it unsecured, right? You're trained in threat assessment, neutralizing threats. If you've served in a combat zone, that hypervigilance can stay with you. So this is a huge kind of pain point for us with trying to prevent suicide. 90% of firearm-related suicide attempts are fatal. Most who survive a firearm-related suicide do not go on to die by suicide. So it is really that acute crisis, like that trigger, the acute crisis. We want people to be able to survive that crisis. Again, it's so quick. It's like 10 to 40 minutes that we're trying to keep people alive for. Just some more information on firearm suicide. 1 in 3 veteran firearm owners have at least one firearm unlocked and loaded. We're seeing an increase in percentage of veteran suicide involving firearms. And there's some more information on there you guys can read as well. Less than 20% of patients at risk for suicide in the emergency department were assessed for access to lethal means. I think that must mean community, because I know for a fact we're screening that and bringing that up with everyone that comes in here. So we know that that's a huge giant risk factor, but it's not something that we're talking to people about. Oh, there we go. So part of my role is really to focus on the secure storage. Oh, I think this is actually going to start. It's just a really quick
Crisis
video.
can happen unexpectedly to anyone. And though it may seem like a small barrier, a simple lock puts space between the thought and the trigger. Learn how securing your guns can help prevent suicide.
So that's an example of like one PSA that the VA puts out. We have the Keep It Secure campaign. We also have a partnership with the National Shooting Sports Foundation on safe storage messaging. This has a lot of momentum behind it, almost like how naloxone became very mainstream. First responders are carrying it. The discussion about firearm safe storage is going to be the same. There's locally, we have the Live Today, Put It Away campaign through Wisconsin. Medical College of Wisconsin has the grant right now with the Department of Health Services. So they have a lot of, they do a lot of education. They work with like firearm retailers. It's kind of a whole project. So you can click on that and learn what they're doing. That's something I'm a part of. I helped do the Rural Wisconsin Safe Gun Shop community of practice call. And then the End Family Fire campaign is new to Wisconsin. It's through the Brady United Foundation. They're like an anti-gun violence, but they're doing this nonpartisan initiative in Wisconsin with the Ad Council. So you'll see their ads coming in the next few years. So I was down in Milwaukee yesterday working on messaging for our side of the state for that. So a lot of kind of focus on this issue, and there's going to be a lot of momentum behind it. So I wanted to quickly go through the SAVE training. There is a video. I don't know if I have the link in here, but there is a video to watch on this too. This is the VA's like public health, same as like QPR, CIS training, like very brief overview on how do you help somebody kind of in the moment if they're having suicidal thoughts. So I'll kind of briefly go through this. If you guys have questions, again, feel free to interrupt and clarify. So SAVE is an acronym. It stands for spot the signs, ask the critical question, validate the person's experience, and encourage and support next steps. So spot the signs. Typically, it's something they're going to say that's going to trigger like, oh boy, we need to have a talk. So hearing things, anything that indicates like hopelessness, like I feel there's no way out of this. I really don't have any reasons to live. I'm feeling really hopeless. I had a friend once tell me, I don't think I'm going to survive this. Big changes in behavior, like really isolating, like giant mood swings, changes in sleep, kind of increase in impulsive risky activities, escalating substance abuse. Those are all things that we can recognize in our friends and family and community members of like, we might need to check in with this person. Other times warning signs may require immediate attention, such as talking about death, dying, or suicide. When they ask, saying they wish to hurt themselves or kill themselves, right? So that's like more imminent threat versus kind of like vague statement. If they have a plan in place, and then kind of increase in that self-destructive behavior, like what does it matter, that sort of thing. So A is ask the critical question. This is the hardest. You have to ask outright. Are you having any thoughts of killing yourself? Have you thought about killing yourself? Get it out of the way. And it's okay if you're way off base. When my friend said that, I don't think I'm going to survive this. I asked her, like, In my brain, doing suicide prevention work, like therapist brain, I'm like, oh my gosh, alarm bells are going off. Like, I'm gonna have to flee over there. And so I asked her, are you thinking about killing yourself? And she's like, oh God, no, I'm being dramatic. I said, okay. Like, and it's okay. It is what it is. And she's like, I was just concerned, like when you say stuff like that. So just don't be afraid to ask outright. I don't think you're gonna offend somebody. And in fact, it kind of shows that you really care and are concerned. So do ask a question if you've identified some warning signs or symptoms. Ask the question in a natural way that flows with the conversation. In that circumstance, I didn't. I just asked outright, and that worked out fine. Do not ask the question as though you're looking for a no answer. That's a big one. Like, you're not going to do anything, are you, to hurt yourself? And then don't wait until like after the fact or they're already walking out. Just spit it out, really. Typically, I just want to mention, I see a lot of people really, really, really good at the S's, particularly like partners, like kids, like you know when something's really off with someone you're close with. And then people aren't as good at the A and the V part. They kind of rush right to like whisking them off somewhere, like intervening, and that's where you tend to lose people. So the A and the V are enormously important. Make sure you ask outright. I've had so many horror stories of somebody tricking a family member, a friend into coming to urgent care and saying like, well, I've seen you been doing this and you said something like this, and like they don't want to be there. It's embarrassing. So make sure you ask. Same with the V. It's really hard to not jump into go mode and want to intervene and start doing stuff, but you have to sit with them. You have to get down on their level and sit with them and let them share their story, share what's going on, listen openly, talk openly about it, and make sure you treat them with respect and allow them to steer things as much as possible, and reassure them that you're gonna stay with them and help. Staying calm, again, don't jump right into like action, go mode. Make sure you look them in the eye. They might be avoiding your eye contact, that's okay. Listen way more than you speak. It should be about like 70% listening and reflecting back versus asking questions. Really try to limit the questions to what needs to be known, and be really supportive. The E is encourage and support next steps. What do you think you should do if somebody is suicidal? So be really honest about your concern. You can just flat out say like, I'm really worried about your safety. You have a lot going on, and I'm just worried about leaving you alone. You don't even have to beat about the bush. I'm worried about you hurting yourself. I'm worried about something happening. Reassure the person that help is available and make sure you stay with the person through the situation. I added this slide in under encourage and support next steps. This is a little more clinical, but I think, again, it's something that's really helpful for the community at large to understand that suicidality is a continuum. So not everybody that has having suicidal thoughts needs to be rushed to the ER, or we need to call a welfare check or police on. And not everybody that like is dismissive of your concerns is automatically low risk. So trying to tease out like, where is this person at? So this is what I do in urgent care. This is what all our clinicians are trained on, is to try to identify what's the acute risk level here. So high acute risk, this is where we're going to utilize emergency measures. So somebody is like, has this planned out, they really intend to die. This is right, like your drunk friend sending off goodbye messages, like alarm bells need to be going off. They might not want help. They might plead and beg with you not to call anybody, but you really need to utilize some emergency measures. 988 is always a great one because they can do a really good assessment over the phone in the moment and kind of give you good advice on what to do. If their person's like actively trying to like hurt themselves or leave, you're worried about something imminently happening, then utilize 911. Every county also has a 24/7 mental health crisis line that you can find on the website. That's also the option, like alternative to 988. So intermediate acute risk, this is where most people fall into. Sorry, my screen just went black. There we go. Oh, there we go. This is where most people fall into, is intermediate risk. So some things might also look like acute risk, high acute risk, but we're not as worried. We're not calling a welfare check. We're not even necessarily talking about psychiatric hospitalization. It's just really there's kind of a like elevated risk present. So they might be thinking about suicide, but have the ability to maintain their safety independently. So kind of my personal example is my friend who had texted me like, I don't think I'm going to survive this. She was going through a divorce at the moment. She had just restarted her medications, like for depression. She was trying to find a place to live and was like sleeping at her office. Like, so clearly some like risk factors at play here that would make me jump to like, oh my God, I need to run over there. But like I was able to pretty quickly clarify that she had no present intent to harm herself. She was kind of worried about like how she was going to cope with this long term. Like kind of like, this is really overwhelming, worried I might do something, but not anything imminent. So this is kind of the example of like I don't need to call welfare check or like be like whisking her off to the ER. Like we can kind of see like she's safe right now. I helped her navigate health insurance. Still didn't want to do counseling, so that's fine. But checked in with her really regularly, like made sure she was safe for a few hours until I got off work, and like went and talked with her. Um, and like kind of talked to her a little bit about her medications just because I have a little more insight, but and some of the side effects. So like just kind of providing that type of support where you're not like doing something that's going to like unnecessarily humiliate them or like kind of overkill. But then I regularly checked in with her, like, how are you doing? Are you still having those thoughts? Where are you at? And like for her, like the crisis had passed, so she was good. And from there on out, she hasn't had any of those thoughts since, and that was like last year. So not everybody even wants or is going to do mental health treatment after this. So if you're not sure, if you're like, oh my God, I hope they're safe, I don't know, you can always consult with 988. That's what they're there for. You don't have to give a name. You can just kind of ask for advice on how to support somebody. Same with the county mental health crisis line. It doesn't mean that you're initiating anything or anything is going to happen. You can just kind of call and be like, this happened. I don't know what to think about it. And then low acute risk, no suicidal intent, no specific current suicidal plan, no preparatory behaviors in place, really high confidence that the person can maintain safety independently. So these are the folks that are like, I just wish I could go to sleep and not wake up. And you're like, tell me more about that. They're like, oh, I would never do anything to hurt myself. I've got my kids, or like they've got really strong religious or spiritual beliefs, like just kind of more like that passive, which we want to still help them get connected with care. But again, we're not sounding the alarm bells or like dragging them in. So this is what the VA uses to stratify risk. This is what our clinicians use, and I think it's helpful for people to kind of understand that continuum. I put some resources in here. Not everybody wants mental health treatment, and that's okay. Maybe they're not ready for mental health treatment. If you're somebody that has a history of PTSD and works really hard to band-aid that and get through your life every day, they might not be ready for like some intense treatment. And that's okay. it can be really hard on family members though, watching somebody struggle. So the VA does, and there's some other good resources too for family members that have somebody in their family that is struggling. So make the connection. This is where you can kind of privately look at health and mental health care. They've got veteran stories. You can kind of navigate through resources. It's a really good website for like family members to use. So there's some better ones coming up. Oh. I love this one. It's called Don't Wait, Reach Out. And this one actually, you take a quiz like on what is going on, and then it will kind of direct you to the right like VA point of contact or like program. So it's free for like community and family members to utilize too, like of like, I have a veteran family member that's struggling, like that's an option in here. So I love this website. Takes the guessing out of it. This is also a fantastic one called Treatment Works for Vets. And this is public information for veterans, family members, and others just interested in learning about evidence-based treatments. So you can read all about like exposure therapy, how to support a family member going through exposure therapy, like substance abuse treatment. And you can like cognitive behavioral therapy for insomnia, problem-based therapy, like all those evidence-based therapy you can learn all about, and it kind of helps look at what might be helpful for your specific situation. The VA has a ton of mobile mental health apps, also free, open to the community. This is great if you're someone that does not want to work with a counselor and you maybe just need some support and guidance, like kind of for people that like to take things into their own hands with their mental health and wellness. So all these different mobile health apps like anger management, insomnia, pain coach, PTSD coach, and there is a safety planning app on here too that matches up with the safety planning that we do within the VA. Specifically wanted to point out Veterans Wellness Path. This was developed with Native veterans and family members, and includes like daily check-ins, different exercises, storytelling. So this is specific for our Native veterans and their family members to use too. So they're all free to use, open to the community. And then the Veteran Online Training Portal. This is a great resource. They're like module-based courses. And again, it's like all different topics. So it'd be like sleep issues, problem-solving skills. There's a parenting one that's really good. My coworker and I clicked through it a few months ago. So these are self-paced modules that people can do from your own device anytime. Also available for family and community members, veterans. And then of course 988. Again, you don't need to be in crisis whatsoever to use it. They just have trained counselors 24/7. What happens is if you press 1, so if you're a veteran or you're calling about a veteran, press 1, it goes to the Veterans Crisis Line. So these are folks that are trained specifically to work with veterans. And what they'll do is offer a consult to our suicide prevention team. So within 1 business day, you'll get a call from the local suicide prevention coordinator in your area for follow-up. And we follow up with family members too that don't even, like the veteran doesn't know that they're calling. Again, everyone can use it. It doesn't have to be a crisis. You can call just to consult. We don't have to get a consult, the VA, but that's certainly offered. And I've even helped like veterans call it if they have a lot of apprehension, just to see like they're friendly, it's okay. Nobody's gonna call police on you. They're there to help. And that's it. I got done 5 minutes early. So are there any questions or comments, or if anyone wants to share?
So we did have one person who had to hop off early, but They just said, thanks for the info, very engaging, and looks forward to the slides. So if you could just send me the slides, I can get them out to everybody else. She also goes on to say, thank you, Chelsea. And it has to have been a very tough job for you. So yes, definitely a resounding thanks, Chelsea. This has been fabulous.
Hard, but good. Love it. The people that are at the VA really were very passionate. Does anyone have any like situations that we can, I mean, even like de-identified or we can kind of debrief on? Otherwise, I can share like a clinical example as well.
We can talk about my husband. He's no longer in the house, and most of the people in this room know him. Not suicide specific, but for a lot of the work I do in means restriction, I run it past him first. He is a Marine Corps veteran, Iraq and Afghanistan, does have some significant PTSD that he's getting help for. But talking about how, okay, we can lock up firearms and that's great, but most veterans can overcome that quickly. If you take the firing pin out of the gun, that's great, but most veterans are going to grab another gun to put a firing pin in, right? Like there's so many workarounds. People who have served know the workarounds. And there's obviously no perfect answer. But any suggestions you have beyond mechanically locking, removing ammunition, beyond that?
Yeah, it's really tough. I would say trying to have a plan ahead of time so that if his mental health is deteriorating, that everybody's on the same page as to what happens. And because you want it coming from the person as much as possible. So even if it's that's like a code word, or I know some people will like have a friend that they trust to come like take them out of the house briefly, even if it's for a few days, or like ask for this doesn't work in Wisconsin because of laws, but I know there's a gun retailer right over the border with Upper Michigan that will accept any weapons for a veteran cleaning, like no questions asked, and store them for them. So trying to make it like really barrier free of like when your PTSD is flaring up, when we see these things happening, like can we just automatically remove them out of the house for a few days until things calm back down? If it's coming from the person and they're more likely to do it, and like engage with that versus trying to like sneak them out when they're out of the house or something. Veterans are really tough because they like are all worried about like home protection. It's like, well, how am I supposed to protect our house? And I always say like, what's more likely to happen in the next week? Your house getting broken into, or you like using it to harm yourself? Like what's statistically more likely to happen this week while things are ramped up, while you're not doing well? So trying to work on people that way. Like trying to find a friend that they trust that isn't going to ask questions and respect their privacy. That'll just be like, okay, I'm gonna swing by and grab them. So I've been in that situation with family members of like having to try to sneak out guns because I'm worried about them. So I empathize. But we've had the most success with when it comes from that person and like having that plan in place ahead of time, before like thinking about that suicide risk curve. Like, okay, we start noticing these things, this starts happening, like we need to intervene early so we don't even get to that point. Or if you're at that point, you don't have access, because it's about that 10 to 40 minutes that we're trying to keep somebody alive.
Thanks. There's another good question in the chat. Are there any ways to make your husband veteran realize that he needs help versus self-medicating? So we live in Wisconsin. We understand the self-medication of alcohol.
Yeah, and unfortunately, alcohol like skyrockets suicidal thoughts and like crises. Like huge number of our suicides are while they're under the influence. I don't have like a magic wand answer. I think about like the technique of motivational interviewing. It's what I use a lot in urgent care and inpatient of trying to build some insight and some motivation for change, but not like coming from top down. So the VA calls it coaching into care. And there's a whole website on coaching into care, because this is again a common problem. I don't have like a good magic wand answer though. It's tough because you don't want to force somebody into treatment before they're ready. Again, people, especially veterans, work really, really, really hard to catch themselves up and function enough to get by in life, but they're not living well and they're not like happy and doing well, but it's enough for them to function. And you kind of, after a long time, forget what good and well feels like. And that's where those MI skills come in, is when you see those glimmers of things going well, like, oh, isn't it great we were able to do these things? And like, what would it take for us to be able to do X, Y, Z? And kind of get them thinking that way. The laws, and if you're thinking like things are so bad that we're looking at involuntary treatment route, the laws in Wisconsin are insanely strict on when we can treat somebody against their will. So they have to be like that high acute suicide risk, like we're afraid something's imminent going to happen, and it's really tough to prove. Only then can we do what's called chaptering somebody, but it has to be done by police and a third party. So that involves, then you have to involve police on your husband or family members. There's no way really to do it without that route, which is really unfortunate because I think we let people deteriorate for long periods of time. Same with, we see a lot of people being brought in unknowingly or like tricked into bringing in, or like kind of given an ultimatum, and we don't typically see good outcomes with that either. It kind of just erodes trust between like the family members. Like I've had people get brought into urgent care, like they were told they were going to Aldi for grocery shopping and then like dropped off, and then like, if you don't go in, I'm leaving you. And like we just don't see good outcomes. It's really trying to build that internal motivation, and having, like, use the metaphor, if you're asking somebody to leave a nice cozy warm fire where they've survived for 15, 20 years with their PTSD symptoms, and this is how they've coped and this is how they've gotten through life, you're asking someone to leave a nice warm fire, you kind of have to, there has to be like an equally warm fire or something more enticing for them to give that up. It's really hard to like rip off that band-aid and do that intensive PTSD treatment. But sometimes like getting them involved like with the mobile apps, or again, like looking at the treatment options ahead of time, just so we're aware of what's available. Having that plan in place of like, if you get to this point, like this is what's going to happen, and everybody's on the same page ahead of time. I don't know if that's helpful or not. It's a really tough situation. But making sure you know what the treatment, when they are ready for help, making sure that you know ahead of time like how to help them and what the options actually are, versus trying to like drop them off at any like emergency room or something. That's always really helpful.
So that makes me think, in a specific situation where a veteran is not, so to say, registered with VA healthcare, so it's never been
Mhm.
seen, can, and JV just puts it in the chat, she's on the same wave, like, can a spouse or family member register the veteran for VA services? Not to make them an appointment or anything, but to register them.
Uh, I'll let you guys weigh the ethics behind like doing this. There, you can just do it online or over the phone, and we have family caregivers help with that process all the time. It's very easy. You have to fill out what's called the 1010 EZ form and then submit the DD 214 discharge paperwork, and they can give you a determination. Like you can ask for an expedited determination, like same day and stuff. Um, so it's really easy to get enrolled in the VA. I think convincing your husband to make an appointment and attend is going to be the bigger challenge. And that, like, we can't schedule an appointment for somebody that doesn't know about it or doesn't want one. And that's more of the challenge. But getting enrolled is like, they've made it very easy these days. A county veteran service or your tribal veteran service officer can help with the enrollment too. Dawson. Yeah, he can help with the enrollment piece. And then in terms of access, that's a can of worms. So how, like, once you're ready for help, like how quick can you get in? If you're open to like video appointments, like very quick, because we can work with like a therapist from any of our clinics. If you want to see like in person, or you have like a gender preference, or um, like that can be a little bit longer wait. But we have what's called primary care integrated mental health. So if you have primary care established with the VA, then you can utilize like same day. We have same day mental health access that's right in the primary care clinic, so they can get you started. Like if you're interested in like substance abuse meds, or like even starting therapy, or uh, meds to help like PTSD symptoms, like target some symptoms, or mood. Like we can work with somebody on targeting symptoms without having to do an entire like PTSD intensive therapy protocol. So like if they're having trouble sleeping at night, we have a lot of things that can help. There's really good medication out there that can help with the night terror symptoms or insomnia symptoms. We also have like a 6-session cognitive behavioral therapy for insomnia. So we don't have to rip open the whole can and let it all out. Like we can target specific symptoms and let you be on your merry way.
We have just a couple minutes left. Does anyone have any more questions for Chelsea?
If you guys ever want to hear more, shoot me an email, or if you want to talk individually, if you need a point of contact and have a whole slew of questions, just shoot me an email. I'll make time. So let me write. That's my email. I'll always make time for a phone call for folks if you're having trouble navigating, that sort of thing. So.
Well, Pinagigi, thank you, Chelsea. Great information. Thanks for answering all of our questions. And thanks everyone for joining us today. As a reminder, the session is recorded and will be available on our Department of Health website and Facebook page. Once I get those slides from Chelsea, I'll email those out to the group. And we look forward to seeing everyone at our next session next week, Wednesday, April 1st. We will be joined by Amy Lord from the Ice Age Trail, and she's going to talk to us about chasing the yellow blaze. We'll find out what that means. You can use the same link as today to join all future sessions. And to add the recurring WebEx link to your calendar, you can email Jamie and I, and we will forward you the invite. I believe I put, let's see, the wrong button. Okay, so our emails are in the chat now, and we also want to hear from you. We ask that you please take a few minutes to complete our feedback survey. I put that link in the chat, and you can also reach out to Jamie and I at any time for any feedback. So thank you, everybody. Have a great rest of your day.